Welcome to AETCM. Today I'll be presenting a case of a 30-year-old boy who presented to our ER with complaints of fever with chills and rigors. So on arrival to our ER, on 10-second assessment, the patient was conscious and oriented, and on airway was patent, there was no secretion, pooling or gurgling. On breathing, air entry was bilaterally equal. Patient had a respiratory rate of 18 breaths per minute with a saturation of 100% on room air. On to the circulatory part, patient had a BP of 100/60 mmHg with a pulse rate of 66 per minute. Disability wise, patient's GCS...
Male or female? This is
male patient. Disability...
Do you think that BP is good?
No, it is towards the lower side. Disability wise, patient's GCS was 15 out of 15. Pupils were equal and reactive to light. And on exposure, temperature was 97.6. Coming to the sample history, the 35-year-old male presented to our ER with complaints of fever with chills and rigors. It was associated with myalgia, headache and loss of appetite since last 3 days. There was no history of cough or shortness of breath. There was no history of any abdominal pain, dysuria or increased frequency of micturition. No history of any vomiting or loose stools. Patient gives a history of travel to Orissa 1 month back. Coming to the systemic examination, at this point of time, we had also sent the CBC CRP, and CBC CRP total count was 4.5 with an HB of 12.9. Platelets came to be as 1,23,000 with a CRP of 7.9. And we had also taken a blood gas analysis. VBG was showing a pH of 7.45 with a PCO2 of 31, and lactate was around 1.3, and all electrolytes were on the normal range, and creatinine was 0.89. So then coming to the systemic examination, patient was conscious and oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Coming to the respiratory system, air entry was bilaterally equal. It was normal vesicular breath sounds. There was no added sounds. Per abdomen, it was soft and non-tender. There was no splenomegaly and bowel sounds were present. On CNS examination, GCS was 15 out of 15, and there were no focal neurological deficits. So at this point of time, since the patient had an history of fever for last 3 days associated with thrombocytopenia, we had started the patient empirically on injection doxycycline 100 mg. We had also started the patient on IV fluid. Since patient's BP was on the lower side, we had started him on 100 ml per hour fluid resuscitation was also started for the patient. And
tell me something about this BP and pulse patients.
Patient's BP is around 160 mmHg and pulse was around 66.
So what do you think? Is it a regular pattern, or you feel something abnormal here?
Usually when if the patient is having severe hypotension, then the pulse rate has to go up, increase.
So that is not seen in this patient. What are the reasons for that in this type of patient?
Patient is a male patient. Patient can be an athlete. Patient is a regular laborer, person who has more physical activity.
Okay, so in that case, even then now it is bradycardia. 60 is a bradycardia. Even then, it cannot be very high, but it has to increase. Physical athlete means normal pulse rate may be 50. So when you have hypotension, it has to increase to 80, 90, something like that.
If the patient is on any drugs, rate limiting drugs, calcium channel blockers.
This patient is not
on any
drugs.
drugs.
So what else you suspect?
If any.
What else?
If there is any autonomic dysfunction. Also.
Autonomic dysfunction means either fixed heart rate. Sitting, standing, taking deep inspiration, expiration. Heart rate is always fixed. Okay. So that is a classical feature of autonomic dysfunction. Not patient will not have bradycardia. What else you suspect? A patient with high degree fever, a slight BP fall, heart rate is not increasing.
Relative
bradycardia means when there is fever, high degree fever, temperature is not increased. He has told fever is not there at present. What else you suspect? Heart involvement. So there is an involvement of heart or conduction system. Okay. Normally when there is only isolated myocarditis, tachycardia will happen. But when the conduction system is involved, there is a chance of bradycardia. Sometimes patient can have severe bradycardia also. So we have to be very careful. Normally, any type of fever, when you have a hypotension, you are expecting tachycardia. Here you are seeing bradycardia. That is actually not a good sign. Okay, we have to be very careful.
So in this patient, since the patient was having a fever with thrombocytopenia and since the patient was giving a history of travel to Orissa, we had also sent the work for the malaria. So Malarian antigen also was sent and patient was started empirically on injection doxycycline. So meanwhile, after the admission, patient was admitted and after the admission, malaria came to be as positive.
Okay.
So then patient was also started on artesunate combination
Which
therapy.
malaria is positive?
He was positive for falciparum.
Falciparum. Okay.
So usually in coming to the malaria and its management, malaria is spread by either Plasmodium vivax or ovale or malaria or falciparum, and the spread is by the female Anopheles mosquitoes, and the incubation time usually it can be between 15 days to 35 days, but it can be also less to 7 days
So
also it can be
the
there.
number of bites. If you have larger quantity of infestation, then you develop the disease very fast.
So the incubation period is that, and coming to the clinical features, most common symptom is fever with rigors and chills. Then it can be associated with the arthralgia, myalgia, headache, nausea, vomiting. So according
What
to the
is reason
species,
for chills and rigors here?
release of paras.
What is it called as? Crisis with lysis.
Lysis.
It's all we learn in basics of medicine. When there is severe hemolysis, you develop chills, rigors, everything. After that, it subsides. Let's say malaria in every 3 or 4 days, you get high degree fever, chills, rigors, everything. Next 1 or 2 days, you'll be all right. Again, there will be high fever, chills, and rigors. Okay.
So there can be a pattern of fever. If in case of vivax and ovale, it can be tertian fever, and in case of Plasmodium malaria, it can be a cotidian fever.
Why we are not seeing all these things nowadays?
Most of this, if it is falciparum, it is not related to anything. And
We don't
people
see
take the
We read all these things in textbook. We don't see anything. Why?
medications.
We take paracetamol. Whenever a patient develops a mild fever, we give paracetamol. Either doctor gives or patient takes. So these patterns nowadays we are not seeing at all. Okay, but when the patient is not on any drugs, you can observe all these things.
Then coming to the Plasmodium falciparum, it is also known as pernicious malaria, and this is one of the most serious among others because it affects the RBCs of all age groups.
Okay.
Hence it is little more severe in intensity, and here what happens is the membrane of the RBC.
Not only one reason. There are multiple reasons for severity of falciparum malaria. One you told correct. It affects all the age groups of like RBC. So the destruction is very wide and severe. Then second thing is? Then
it can affect the membrane of the RBCs leading to the rosette formation and cytoadherence
rosette formation. So it can block the microvascular. Third one? Third one. What is it? The reproduction levels are very high. Since you told it is affecting all the RBCs, you should just imagine the number of parasites produced are very, very high. So the infestation of next level of RBC is also very high, and ultimately all these things utilize the sugar. Okay, the number of parasitic load will be very high in falciparum. They utilize the sugar. So most of these patients will develop hypoglycemia. So falciparum is severe because of multiple reasons. Okay.
And then coming to the severe malaria symptoms, the most common symptom is hypoglycemia. Hypoglycemia occurs because one thing is that the parasites utilize the glucose. Second is when it affects the liver, then your gluconeogenesis is affected and all your glycogen storage also will be utilized. And the third reason might be if we are giving quinine as the treatment, then quinine itself can cause increase in insulin production and patient can develop hypoglycemia.
What are the side effects of quinine? Nowadays we are not using it. What are the adverse effects of quinine? You told hypoglycemia is one of the common things. That's why we are mixing quinine in DNS and giving. Okay, so that is one of the major reasons. Second thing?
Then it can cause drug interactions can happen. Then it can cause arrhythmias. QTC prolongation can be there leading to torsades pointus can happen.
So these three things are very important. Interactions, QTC prolongation with the torsades T point is hypoglycemia.
So the quinine toxicity we classically call it as synchronism. Basically patient will be having tinnitus, nystagmus and dizziness. So quinine induced
malaria itself produce all these things: tinnitus, nystagmus, giddiness. Malarial cerebellitis, there is an entity. Malaria can affect the cerebellum. They can have all these features. So when you are treating with quinine, you will have confusion whether it is malaria producing problem or quinine producing problem, synchronism or malarial cerebellitis.
Then the second other symptom will be lactic acidosis. One will be due to the less clearance by the liver, and the second one will be more production by the parasites. And also due to this cytoadherence and rosette formation, it can be also due to the less perfusion to the organs. So all these can lead to the lactic acidosis in patient. Then patient can develop.
So if lactate is elevated, will you classify it as severe malaria or mild malaria?
Usually
automatically it will become severe. Okay, so lactate is one of the most important indicator in emergency room whether the patient is having severe internal tissue damage or not. Okay, like in sepsis, here also lactate levels are very important.
Then the third symptom can be jaundice. Jaundice can be due to hemolysis itself and also due to the involvement of liver.
Both are different or same? Jaundice of hemolysis and jaundice of liver injury, both are same or different in lab investigation wise?
Different.
How different?
Direct bilirubin and
so one is indirect, other one is direct.
Then patient can go into renal failure due to the reduced perfusion to the kidneys. Then patient can develop severe anemia one is due to the hemolysis by the parasites. Second one will be there will be increased sequestration, splenic sequestration, and third one will be due to the cytokine suppression of the bone marrow. So patient can go into severe anemia. And then CNS manifestations like seizures can be there, impaired GCS can be there. Patient can go into coma.
What is cerebral malaria?
In cerebral malaria, patient develops mostly the CNS manifestation. So patient goes into coma state.
Define. Definition means see the patient can have hypoglycemia and coma. Patient can have cerebral malaria and coma. So patient is having altered behavior or comatic state or encephalopathy, but you have to rule out hypoglycemia. So hypoglycemia is a strong differential diagnosis for cerebral malaria because both the condition can be seen in falciparum malaria. So some patients with hypoglycemia we may misdiagnose it as cerebral malaria. There is nothing wrong in overdiagnosing. Okay.
Then patient can have generalized weakness, prostration features. Then patient can also develop bleeding due to the thrombocytopenia, and then in the later stages patient can develop shock and DIC. So these are the features of severe malaria. And then in malaria there are two common terms what we use, that is the relapse of the malaria and recrudescence of malaria. Relapse is after an attack, the dormant parasites in the liver can cause a reactivation of the infection.
That is common in?
That is Vivax. So there we give primaquine to stop the relapse, and recrudescence is due to the ineffective treatment. The parasites in the RBCs can cause another recurrent infection within weeks or months. So that is the recrudescence. Then coming to the investigation part, the most commonly used is the peripheral blood smear. So we can go ahead with the thick smear and the thin smear. In the thick smear we will be able to know whether the parasite is there or not, and in the thin smear we will be able to differentiate the species. And then the most commonly used one is the Buffy code we can go. So quantification, QBC, quantification Buffy code can be there. We will be taking in the capillary tube the blood and adding ecridin orange, and under the UV rays we can see the fluorescent parasites at the level between the RBCs and the Buffy code. So here we can quantify the parasites also. Then a rapid antigen test can be done. Then monoclonal antibodies against the histones can be done. Plasmodium LDH test can be done. PCR also can be done. All these are the most common investigations. Then coming to the treatment.
What is the problem of this thick smear and thin smear?
Because it is observational variation can be there.
It's a user defined test. If the user is not very good in seeing the fields, then you will miss it. Okay. So clinically you have to diagnose. Malaria is like that.
Then coming to the treatment part of the malaria, according to the Indian guidelines, if it is a chloroquine sensitive and it is a Vivax species, then we can go ahead with the chloroquine treatment. That is chloroquine 600 mg stat will be given, followed by 300 mg at 6, 24 and 48 hours. Along with this we will be starting
chloroquine 600 contains how much base?
250 mg tablet will be containing 150 mg base.
So first
four tablets will be given, later 2 tablets each will be given. So it will be given on 6, 24 and 48 hours. Along with this, we will be starting our
What is the
primer.
other advantage of chloroquine?
Fever will subside.
Immediately fever will subside. Even if malarial fever is very spikingly high, if you give chloroquine, the anti-inflammatory action will be there. So there is nothing wrong in giving chloroquine in malaria. Because sometimes you will not be able to give paracetamol. So you give chloroquine and give your resistant tablet also, whatever tablet you are preferring.
And along this, we will be giving our tab Primaquine 50 mg per day. That is at a dose of 0.25 mg per kg per day can be given for 14 days. And if it is in case of Plasmodium falciparum,
guidelines say you finish the treatment of malaria, then you start Primaquine. Okay, some guidelines is like that. After the treatment of acute malaria, start the prophylactic treatment.
Okay. Then in case of Plasmodium falciparum, we will be going ahead with the artemisinin based combination therapy. So in states other than the northeastern states, we will go ahead with the artesunate with sulfadoxine or pyrimethamine. So artesunate will be giving at a dose of 120 mg stat dose and followed by 60 mg for 6 days, once daily for 6 days. And along with that, when we are giving sulfadoxine, it will be at the dose of 25 mg per kg OD, and if it is pyrimethamine, the dose will be 1.25 mg per kg single dose. So this will be going, and on the second day we will be giving Primaquine at a dose of 0.75 mg per kg.
Okay. But
So
this consider that drug is not available in most of the states. You can go for alternative. Like you can go for doxycycline, you can go for azithromycin. Any alternative also will be useful because we are giving dual therapy to prevent resistance.
So in second day, Primaquine also will be given. Then in northeastern states, instead of the artesunate, we will be going ahead with artemether and lumefantrine. So artemether will be giving 80 mg daily and lumefantrine will be giving 480 mg daily. Along with the on second day, Primaquine dose also will be given. And in case of severe,
Is there a reason for that? Is there any reason? I don't know. I'm asking. You are from northeastern states, so you can tell us. At least you can find out what is the reason. Maybe some reason will be there.
And in case of severe malaria, then we will go ahead with IV medicine. So here we can give artesunate IV 2.4 milligrams per kg will be given at 12, 24th and then daily dose will be given. If artesunate is not given, then quinine also can be given. So initially a loading dose of 20 mg per kg will be given, followed by 10 mg per
Quinine
kg.
should be avoided in following condition. What are the conditions?
Pregnancy, it has to be.
That is the most important. Pregnancy you are not supposed to. There are all conditions you can safely give, but like you told, arrhythmias can be there, so under monitoring only it should be given.
Then along with this will be
What is Torsades D point is? She was telling what Torsades D point is. It's a polymorphic reading. Okay.
Then we will also be giving doxy 100 mg BD for 7 days, or clindamycin we can give 10 mg per kg followed by 15 mg per kg for 7 days. So these are the guidelines. And then coming to the chemoprophylaxis, if the patient is traveling to an endemic area, then
one more thing, if the patient is having, you might have seen some of the malaria cases, procalcitonin levels are high. What will you suspect?
So any gram-negative superadded infection also should be suspected.
That is very common. Superadded infection with gram-negative infections are very common. So
Salmonella most common.
Either you can suspect in an endemic area, if you are getting repeated cases, you have to treat. Otherwise, you can send procalcitonin and see. If it is high, you have to start with ceftriaxone. So endemic fever is very common with malaria due to some reason. HIV also very common in malaria infected patient, not because malaria is inviting HIV. HIV patients can have more incidence of malaria.
Then coming to the chemoprophylaxis part, so it should be started 1 to 2 days prior to the travel and then should be continued 1 week after the travel also. So here we will be giving, if it is chloroquine sensitive, then you can go ahead with your chloroquine 150 mg tablet to 2 tablets, that is 300 mg can be given weekly once, or proguanil 100 mg daily can be taken. And in cases of chloroquine resistant, you can go ahead with your mefloquine 250 mg weekly once, or you can go ahead with your doxy 100 mg daily dose. So this is the
What is the advantage of
chemoprophylaxis.
doxycycline going to endemic areas? Taking doxycycline.
Once you can prevent and then
It
resistance.
is useful for so many prevention of so many diseases.
Tropical fever.
Tropical fever, sexually active, sexually transmitted diseases, then malaria, so many other conditions. Doxycycline is useful. Let's say doxycycline is a very useful drug in when you are traveling various endemic areas.
Yes. Then patient who is on chloroquine prophylaxis, if they develop malaria, it will be severe, and then it is known as black water fever. It can be called as. Then if there is a super added gram
Black
negative.
water fever means what? They have more hemolysis, dark urine, dark color skin. All these things are common. Okay.
And then algid malaria, as we have discussed, when there is a super added gram negative infection, it is known as algid malaria. Then
what are the common side effect of chloroquine?
Chloroquine.
Anticipated side effect in certain ethnic groups, not in all.
G6PD deficiency hemolysis can happen.
So if that happens, what will be
you
the
have to
clinical-
stop the drug, start on folic acid, you can start. Hemolysis will
How
be
do you
there.
know that?
Urine discoloration will be there.
Okay. So nothing to worry, stop the drug, start folic acid.
So here in this patient, we had initially started with doxycycline. As the malarial antigen came to be positive, we had started him on artesunate.
Okay.
So 120 mg was
Is
given.
there any side effect for artesunate? No major side effects. Is the resistance is common with
Yes,
artesunate?
no.
Resistance can
Be
happen, but it is very less. Comparing with quinine, it is very less.
So we add another drug class
To
of drug
prevent
also.
that, we are adding one more
Doxycycline or
drug with the
Artesunate.
artesunate.
So here we had started the patient on artesunate for 3 days, and then following that we had also put on primaquine also we had started. So we had given initially 45 mg stat dose, and following that on 15 mg for 14
Why
days
it
was
is like
given.
that? 45 mg stat is for falciparum, 15 milligram for Vivax. Now here our diagnosis is only falciparum.
Falciparum.
Why?
A mixed
Because
infection
most of
can
the time
happen.
This will be combined infection. We will be picking up only falciparum. We may fail to pick up Vivax, and after some years he'll come back with malaria. So that is better to give because it is very difficult to pick up these diseases.
So we had initiated primaquine for 15 days and 14 days and discharged him. On discharge time he was stable and his platelets were uptrending.
Okay. Anything else? Can this malaria spread from one person to other person?
Mosquito.
So only through mosquito. So nothing to worry about that. Okay, thank you.
Thank you, sir.